great audience today. Okay. Any other questions before we get started on the schedule? So we're fairly on track. Okay, easy. What do you call a fake noodle? A fake noodle. It's pasta. All right. What does a nosy pepper do? It's all up in your business, right? All right, how about this one? Let's see if you guys get this. Would it be all up in your business? Would that be better? Okay. All up in your business? All up in your business? All of it. Do I need to spell it out? It gets less funny the more times you have to do it. This is how it is with my mother. You know, it's just like, I don't really understand. You know, never mind, Mom. All right, I think you guys will get this one. Maybe not. I mean, you'll understand the joke, maybe. What do you call a person who doesn't toot in public? A private tutor. My kids really like that one. A private tutor. So, all right. It's the best kind, actually. All right, so we're entering into the endocrine section. I updated the slides a little bit for simplicity because I want to try to trim things down a little bit. So if you didn't download the most recent deck, there aren't any new slides in there. There's actually slightly fewer. Okay, so you'll be able to hopefully follow the flow. And there's like 2.5 slides of drugs, you know, and it caused a lot of problems. Students are like, I always got the question of, do I have to memorize all those drugs? And it was fun just to say yes and see how good. Like, does it seem like too many? Yeah. All right, well, maybe just focus on half of them. You pick which ones, okay? But the point of the drugs is to talk about drugs that are used for diabetes. So, you know, if you downloaded the new one, because you're kind of the last minute type, you don't have those slides. If you want those, I will upload them for you. But I just kind of trimmed it down a little bit. But before we get started, we need to talk about a little bit of review with the endocrine system. Now, I want to talk about the differences between endocrine and exocrine. The endocrine system is a system of glandular structures, and they secrete usually a hormone-like product or a protein. And typically it goes into the bloodstream and it's going to circulate around. Okay, that's endocrine. Endo meaning inside. Exocrine, these are also glandular structures, but they're products, usually proteins. They could be hormones, but they could be other types of chemical messengers made up of proteins. And these guys are released into ducts, not the bloodstream. And these ducts empty into or onto surfaces. But the key is that that surface is contiguous with the outside environment. So, for example, if you think about exocrine sweat glands, they're releasing products via a duct onto the surface of the skin, outside environment. If you think about pancreatic exocrine function, the pancreas has dual activity, right? Endocrine and exocrine. But the exocrine function is for digestion after a meal. And it's releasing these products into the outside environment because the lumen of the GI tract is contiguous with the outside environment. It's not until you absorb those materials across that basement membrane that it becomes part of the internal environment. Okay? Right? Why, if you eat something that doesn't agree or is problematic, then it's either going to not, the goal is for it not to be absorbed into the environment, internal environment. So you want to move it backwards and get it away so it doesn't absorb, or you want to move it forward very, very quickly. Right? And if it goes backwards, then it's regurgitation, and if it goes quickly, it's through in the forward motion, it's diarrhea. So endocrine and exocrine function are very, very different, although they're similar in the sense that they use glandular structures. Now, there's a couple of other terms that I want to remind you of, and those terms are paracrine and autocrine. Para, we've talked about this in the class before, but paracrine is a response. We can define paracrine.
Cells secreting a hormone that affects local neighboring cells?
Local or adjacent neighboring cells. Paracrine. And then how about autocrine? Auto meaning self. And so, what was an example that we looked at earlier in the semester with an autocrine signaling?
Lymphocytes?
What's that?
Lymphocytes?
Lymphocytes in our immune system. We looked at IL-2 expression. Do you guys remember that? And how it had a co-stimulatory activity on cytotoxic T lymphocytes. Okay? So we've already looked at some of these, but I'm telling you the whole gamut again as a review. This is review. We have exocrine, we have endocrine, we have paracrine, and we have autocrine. Okay? Now, if we look at hormones and we classify hormones, we can put them really into four main categories. And again, you guys know how I feel about these categories. These categories are categories that we make up for simplicity, to make it easier on ourselves to talk about them, to ask test questions, right? The first category would be peptides. These are fragments of proteins. They're secreted into the bloodstream. Some examples would be like prolactin, bless you, or that would be from the anterior pituitary, or from the posterior pituitary, antidiuretic hormone, ADH. We'll look at both of those today. So these peptides are fragments of proteins, the ones that we kind of classically think about. Steroids. Steroids also could be a hormone. Steroid is an organic compound, and it is typically derived from the cholesterol molecule. And so some classic examples will be the sex hormones like estradiol and testosterone, types of steroidal classification of hormones. Or the anti-inflammatories. The anti-inflammatories like a steroid known as dexamethasone. That's a synthetically derived drug that's made from a steroidal cholesterol backbone. The monoamines. These monoamines are usually derived from tyrosine. And some examples of monoamines are going to be norepinephrine, epinephrine, dopamine, and the thyroid hormones. Okay, the thyroid hormones, both T3 and T4. And we'll look at T3 and T4 today. And then our last family or category is known as the eicosanoid family. They come from arachidonic acid. You guys probably remember that from earlier this semester. These eicosanoids, do you guys remember some examples of eicosanoids that came out of arachidonic acid as a starter precursor? Thromboxane, perfect. What else? Prostaglandin, prostacycline. And then the last one was the leukotriene family. Okay, so these are derived from this 20-carbon chain, arachidonic acid precursor. Okay, so these are our main families of hormones. Now, how do these hormones act? How do they work? Mechanism of action. Well, the hormone's going to circulate around. It's going to bind to a receptor, a very specific receptor. And that's important because you don't want the hormone binding to random receptors causing problems, okay, or non-specific activities. So the receptors are very specific, and they have a saturation point, meaning that only a certain amount of ligand will bind, and then you won't get more of a response. But we have the ability to amplify our signal. And the amplification can happen in really two main fashions. We can upregulate or we can downregulate. So if you look at this effect, and we just came out of the nervous system, and we looked at the review on the nervous system, and we looked at different disorders. And the nervous system strategy, right, for our body, the motif is you can provide a very rapid and localized response with the nervous system to change, to influence homeostasis. That makes sense? So, for example, think of heart rate. Now, with heart rate, if you want to quickly modify or modulate heart rate, you do that with neural innervation. Right? The first thing that you do is you actually decrease the signal from the vagus nerve that goes to the heart. You slow down that signal, or you completely inhibit it altogether. Because the vagus nerve is a parasympathetic response that lowers heart rate. Resting heart rate of you in this room, probably right now, is probably right around 60 plus or minus 15, 20. Some of you could be in the 40s, bless you. Some of you might be, up in the 80s, but probably 60 plus or minus 15 to 20. Okay? Now, if I say the word exam next week, then that number probably starts creeping up. But the autonomic or the set resting point heart rate of the heart is what? Do you guys remember this from 202? 100. It's about 100. Okay? So the SA node fires at about 100, at a frequency of about 100 beats per minute. And the vagal nerve is innervating and sending parasympathetic activity to take it from 100 down to 80 or 60 or 40. So the first thing that you can do, if we had a fire alarm go off, is you could decrease parasympathetic outflow to the heart and really quickly raise it to 100. Okay? Then you have sympathetic outflow. Usually in the case of the fire alarm, it's going to be modulated by norepinephrine or epinephrine, and you're going to raise it from 100 on up. Your max being about 220 minus about your age. Okay, so in this room, your max heart rate is probably about 200, about plus or minus 10. So the quick response can be nervous system. And then that delay, you've seen this happen. Like if you wake up to a fire alarm in the middle of the night, right? You come out of a dead sleep, right? And then you can count the seconds, but it's about 3, 4, 5 seconds later. Now your heart's like coming out of your chest, right? So the hormonal effect is slower. The nervous effect is actually much more quick. However, one of the advantages of hormonal is you can actually influence or modulate the whole organism because it travels around the body. So this is good for metabolism. This is good for sexual organ development. Right? This is good for growth of bones and muscles. You don't want to just what's wrong with your left arm? Oh, it's growing this week. So they grow like at the same rate. Okay? Your legs grow, your whole body, your growth plates are all being hormonally influenced all at the same time. Okay? So if you look at this map, you get a small stimulus, you use a hormone, that's that box at the very top of this sort of pyramid, and you cascade it down through second messenger systems, activating enzymes, creating a metabolic product, which takes time to manufacture these hormones. And then you can create a broad or a great effect across the entire organism. Like in adolescence, let's grow the entire organism all at the same time. Okay? Now we have a couple of different ways that we can modulate this. Upregulation is this first panel right here. And downregulation is this bottom three panel, moving from left to right. So if we look at upregulating, we can upregulate our receptor. So for example, if you have a low receptor density and you release hormone, keep in mind that the relative concentration of these hormones doesn't really change all that much during these major events. So you measure hormonal flows within men and women, or boys and girls during adolescence, and the relative blood levels are going to be about the same. Those that grow really tall don't necessarily have more hormone being released, okay? It's more likely that they have a greater receptor density. So you increase the expression of the receptor on the target cell, and now you have a stronger response. Now, likewise, if you want to downregulate the signal, you can count all these little dots of hormone that are above the cell. But the idea is that the hormone is about the same here and here on either side. But now you downregulate the receptor, and you actually slow down the effect or slow down the response. So when we look at hormonal activity across the organism, now we need to talk about three main ways that they act. Because hormones usually don't act independent of themselves. They usually have other hormones that are coming into play. Okay, so if you look at the female menstrual cycle, you know there's two main players. We have estrogen and we have progesterone. And you usually don't see the hormonal cycle without both. Okay? So the three categories that we're going to look at are synergistic, antagonistic, and permissive. I'll talk about antagonistic I'm going to talk about permissive first because I brought up estrogen. So permissive, the last one on the list first because we talked about estrogen and progesterone. The hormone has a permissive activity if it enhances the target tissue's response to a second hormone. It permits something else to happen. So for example, keeping true to this female menstrual cycle example, estrogen has a permissive activity in that it stimulates the upregulation of progesterone receptors in the target tissue. And so it works in concert in that way with a permissive activity. If we work backwards, antagonistic on the list, the second one on this list, they have opposing actions. So insulin is going to lower blood glucose levels, and its antagonist is what? Glucagon. Glucagon is going to increase blood glucose levels. Those would be antagonistic effects. Then the last one, which is our first one on our list, just because I talked about the permissive example first. Synergistic. What is synergistic? What's that example? Or tell me what it means.
The combined effects of both the hormones is like stronger than just one of them?
That's exactly right. So the combined effect of both hormones is greater than just the two of them together. So another way of saying that would be 1 plus 1 equals 3. Okay? You're like, I knew it. I knew I didn't miss that. Second grade. Mrs. Gardner was such a terrible teacher. So synergism. It's greater than additive. That's another way of saying that. So follicle stimulating hormone and testosterone, so FSH and testosterone, are necessary for adequate sperm production. If you just have one, you don't have sperm counts in the male that are at normal physiologic levels. You need both. Okay? They act synergistically with each other, greater than the sum. Okay, so next up on our summary list, in the last little segment, this is all review, but I spend a lot more time in endocrine review because I think endocrinology is actually rather fascinating. I think it's rather difficult. Okay, I think clinically it's one of the more challenging fields because there's a lot going on. So if you look at this figure, we talk about these axes. Okay, so the axes are coming down from essentially the brain. We've got the hypothalamus at the top, and then we have these two lobes known as the pituitary gland collectively. The lobe on the left is considered the anterior pituitary, and the lobe on the right is the posterior. Okay, the posterior really being more neural tissue, and the anterior being truly endocrine tissue. But we'll get there here in a moment. So what I want you to be able to appreciate as you look at this slide is from the anterior pituitary, which is shown, you actually have an axis of activity down to target tissues that have various effects throughout the body. And in endocrinology, when you've looked at that segment in 202, You remember studying all these things. Like, so for example, we have target tissue at the level of the breast tissue, the thyroid, the reproductive organs, the adrenal cortex of the adrenal gland, over on muscle, fat, as well as bone. So if you have a problem systemically with growth hormone, right? If you have a problem systemically with growth hormone, the question that I pose to you is, do you know where the issue is with respect to growth hormone? Let's say growth hormone is too low in this individual. What's the problem? That's all you know. I have blood work and growth hormone is low. Where's the issue? Okay, not what the clinical sequela is, or the result. Where's the problem? Why is growth hormone low? What's that?
Have like many, have different ecologies.
Yes, it has different places where it could have messed up, so where are they?
Anterior pituitary.
It's the anterior pituitary,
Or the hypothalamus.
or it could be the hypothalamus, right? So you don't really know. You don't know if it's a hypothalamic problem, because the hypothalamus tells the pituitary to release. Okay? What about if you look at thyroid hormone? That's another one. We'll look at both of these examples today. So thyroid hormone is too high. What's going to go on with the patient then if thyroid hormone is too high? Metabolism is up or down? High, okay? So you have thyroid hormone that's too high, elevated. Okay, where's the problem? It's in the thyroid, right? Because the thyroid's making too much. Is that true? You're positive? Let's just cut the thyroid out, or, cut half of it out, make half as much. So what else could be the problem besides the thyroid?
Thyroid stimulating hormone?
Thyroid stimulating hormone. Where does that come from?
The anterior pituitary.
It comes from the anterior pituitary. Okay, let's go with Blake anterior pituitary. That's perfect. I like that doctor's answer. Don't touch the thyroid. Let's go into the anterior pituitary and get rid of that thing. Okay. Is that the only place that can be problematic? Hypothalamus. What does the hypothalamus release? Thyrotropin releasing hormone that has activity on the anterior pituitary to relieve thyroid stimulating, which has activity on the thyroid to make T3 and T4. Do you understand why I'm saying it's complex? Right? So you have to be able to follow these axes, and that's why you go through endocrinology in 202. So let's review some of the products that come out of the hypothalamus. They're listed here, but you may not remember the nomenclature. So TRH, that's thyrotropin releasing hormone. TRH, out of the hypothalamus. Gonadotropin releasing hormone, GnRH. CRH, corticotropic releasing hormone. So the hypothalamus in the brain has these releasing hormone activities that come down, and they have activity on the anterior pituitary, and it's going to release different products. So the anterior pituitary, for example, it releases thyroid stimulating, we just talked about. And that's going to go down to the thyroid and cause the thyroid to have its activity. We've got luteinizing hormone and follicle stimulating hormone that come out of the anterior pituitary. And they have activity on the reproductive organs down here, LH and FSH. And then we have adrenocorticotropic hormone. It comes from the anterior pituitary, ACTH, and it's being caused to be released by the hypothalamic release of CRH, which is corticotropic releasing hormone. And then the last one is, that's not really shown on the figure, that's anterior pituitary derived, is growth hormone releasing hormone. So growth hormone releasing hormone comes from the anterior pituitary, and it causes growth hormone to be released. Okay. and it has its effect more broadly throughout the body, like in the liver, fat, muscle, and bone. So if we look at organization of the hypothalamus and the pituitary gland in more detail, again, this is still in this category of review. All of this should be familiar to you. You may not be intimately familiar with it. It's a little dusty, but hopefully you're like, oh yeah, I do remember talking about these two lobes. Okay? So maybe it would be a good idea to kind of review. That's why we're going through, you know, a good 30 minutes of review before we dive into it. So the hypothalamus, you can see here's our hypothalamus up top, and here is our anterior lobe, and then here is our posterior lobe. Okay? Now our anterior lobe is truly the endocrine structure. The anterior pituitary is considered to be one of the primary organs, or the major organ of the endocrine system. Now, the posterior pituitary has a second name. It's called a neurohypothesis, right? And it is more neuronal axons, projections from the hypothalamus. And a lot of this material that comes out, there's two main products. Do you guys remember what they are? ADH and oxytocin. Antidiuretic hormone, ADH, also known affectionately as vasopressin. Okay? And oxytocin. What does vasopressin do?
Retains water.
ADH. What is it? It retains water. Okay? It has activity on water retention so that you raise blood pressure. Okay? You don't urinate out and lose a lot of your water. Antidiuretic hormone. So a diuretic makes you pee. An antidiuretic actually conserves water. Okay? Oxytocin, this stimulates lactation and uterine contractions. Oxytocin. So those products are actually from the posterior pituitary more as neuronal axonic flow or transport within the nerve, and then they're released. Okay? Versus the hypothalamus releases its products into the circulation, then they get down and target the anterior lobe and cause it to release new products into the circulation. Whereas the posterior lobe, the product is made up in the hypothalamus and it's transmitted down via the axon into the posterior lobe, and then it's released out of the posterior lobe. Okay? Questions over our review? Is that helpful to orient us where we are? So, endocrinology is rather complicated clinically because of these axes where what's happening at the hypothalamus influences the anterior pituitary, which then influences all these different target tissues. Okay? Now, if we look at that organizational structure, now we can start diving into the different organs and start looking at where things go wrong. Where things go wrong have these different categories. Most oftentimes in endocrinology, it's going to be into two main categories. You're either going to have too much of a hormone, or you're going to have too little. It's really the only options. If you have just right and it's homeostatic, then you're normal physiologic and there's no issues. Now you could have slightly too much, or you could have a lot too much. Make sense? But if you have hypersecretion, then you're making too much of it, and a lot of times there's a center that is hyperactive within that organ, and we'll call it an ectopic foci. So it's not necessarily the whole organ is overproducing. There might be just certain regions that are overproducing. Now, one of the ways that's most common for that to occur in ectopic focus, or an area of tissue within the organ to overproduce, is when it becomes an adenoma. When it becomes overly mitotically active, but it's benign, right? So it's not going to metastasize. It's not really cancer. It's still producing hormone, but because it's growing and it's overly active, it makes more hormone than it should. Meaning the region right adjacent to it is making normal levels, and that area is making too much. Okay, so that's why, well, they found a mass of some sort on my thyroid and they want to go cut it out. Okay, that's kind of what we're talking about. And it's making too much thyroid hormone. So they'll come in, they'll cut out that lesion, they'll they'll send it out for pathology and determine, is it benign or malignant? If it's benign, then they probably just leave it. If it's malignant, then they'll come in and they'll more aggressively take out maybe the whole thyroid. Now hypo is undersecretion. Undersecretion, well, what would happen there? Well, you could have a lot of different things, and we'll talk about throughout today. But you could have cancer that is growing to an extent, and now it stops producing hormone because it's no longer looking like the tissue it's supposed to. In addition to that, it's growing so large that it's putting pressure on surrounding functional tissue, and it's shutting down their activity. Okay, so you could have a cancerous event taking place, and the patient could either be hyper or they could be hypo, depending upon where the cancer is and what stage it's at. Make sense? So again, not only is it difficult to figure out where in the axis are we talking about the issue, now it's also problematic to figure out what's causing the issue. Is there a mass or an adenoma in the brain at the level of the hypothalamus or in the anterior pituitary? Well, we'll have imaging help to determine if that's the case. That's a whole lot harder to get to because it's in the cranial cap than the thyroid, which is just in the neck. Okay? But you're not going to go digging in the neck just because that's the easier place to surgically approach. So you're going to want to diagnostically approach this and say, okay, what else could I look at? What other questions could I ask to try to pinpoint and identify where the problem really is? You with me? Okay. So now we have abnormal interactions that come between the hormone and the target organ if you have too much or too little. And then you're going to have an abnormal target tissue response. So the manifestation that you guys are trying to jump to, which I get, we'll get there, is if you have too much or too little, if you're talking about, for example, growth hormone, now the individual could either be too small. Now they won't be a dwarf. That's not a growth hormone necessarily issue, right? That's an epiphyseal plate issue. But they might be small in stature but proportional, or they might be large in stature and proportional. That would be truly just a growth hormone issue. A chondroplastic dwarfism. Some of you didn't take my 201 class, but we do talk about it in there because that's an issue at the level of the growth plates, the long bones. And so with those individuals, the cartilage isn't responding to calcification or to ossification. And so the growth plates never elongate. So the short bones in the hands and the feet, and then the arms and the leg, they don't necessarily grow. They stay small, like children's size. But the trunk, the head, right, for a chondroplastic dwarf, or a little person, okay, there's lots of terminology. I'm not exactly sure what's supposedly, PC these days. Those individuals are very short in stature, but they're not proportional, meaning they have shorter arms and legs, and their trunk and their head is like normal size, adult size, excuse me. Okay? So what we're talking about with growth hormone is the whole individual gets really, really big, or they stay very, very small. Okay? Do you guys remember Andre the Giant? He was like a wrestler back when like WWF was really big, like Hulk Hogan days. I don't know if you know. You could YouTube it if you don't know what I'm talking about, or Google it. He was in The Princess Bride. That's right. He was an actor later, but he had growth hormone gigantism, and we'll talk about that here in a minute. Okay. So if we look at the hypothalamus and we talk about what its main duty is, what is the main role of the hypothalamus? Who can tell me that? Don't all speak at once. I mean, it's hard to understand when you're all talking. What does it do? Any ideas?
Monitor levels of body, like keeping body at homeostasis.
Yeah. It's the homeostatic center in the brain. Things like temperature, things like thirst, right? Things like hunger, pleasure, rage, aggression. It has a lot of these homeostatic roles. So hypo meaning under, right? Remember hypodermis is that layer beneath the dermis. So hypothalamus is underneath the thalamus. Okay, so it sits right below the thalamus. Thalamus is the main relay center of the brain. And then we looked at these on the last one, but let's just go over it. GHRH, gonadotropin, growth hormone releasing hormone. That's what it makes. It also makes growth hormone inhibiting hormone, which blocks growth hormone's activity. Another name for that is somatostatin. It makes PRF. That's prolactin. PRF is the abbreviation for prolactin. And then PIF is prolactin inhibiting factor. Prolactin inhibiting factor. GnRH, that's gonadotropin releasing hormone. TRH is thyrotropin releasing hormone. And that is being released to stimulate what from the structure below it? What does thyrotropin releasing hormone stimulate? The anterior pituitary release. Thyroid stimulating hormone. Very good. Just seeing if you can follow the axis as I'm reviewing this. CRH, corticotropin releasing hormone. Okay? So these are the products that the hypothalamus makes. If you look at, here is the structure of the thalamus, and the hypothalamus sits right below it. And this circle that's blown up over to the right, you can kind of appreciate, here's our hypothalamus up top, here is the anterior pituitary, which is going to sit within the sphenoid bone, right? It sits within that sphenoid bone, which is part of the skull. You guys remember the sphenoid? So the sphenoid bone is kind of like that bat-looking structure bone that's in the middle of the skull. Okay, and it almost reminds me of a cranial vertebrae. Now, you know how you have vertebrae that run all the way down? So it's kind of positioned right above C1, but in the middle portion, and it kind of has like a vertebral shape to it. And so it kind of is like a strap that runs across. And in the center of that sphenoid bone is where this anterior pituitary sits. Okay, so that's what we're talking about here. Now, if we talk about functionality and dysfunctionality of the pituitary, let's go through our different options, right? We could have hypersecretion, hyperpituitarism. So if you had an adenoma, the question, where is this adenoma in the pituitary if it's endocrine problematic? Which part of the pituitary are we talking about? Anterior pituitary. Okay, that's where most of these adenomas happen, is in the anterior pituitary. Now, they can be classified based upon the type of hormone that's being released. Okay, so the adenoma, if it is upregulating the production of hormone, it could upregulate that hormone from the pituitary in any one of the hormone families that we talked about. And it's going to have a name associated with it that tells you it's probably within the lineage of one of the previous hormones that we talked about. Like, for example, growth hormone releasing hormone is problematic. Now, the adenoma is classified further based upon its activity level. So if it's a functional adenoma, then it's manufacturing hormone with clinical effects. It's doing something. Too much, but it's doing something. If it's silent, the second option is the hormone is manufactured, but it doesn't work. So it's not a functional hormone that it makes. You can measure it, but it's not working. Or it could be hormone negative, the last one. So no hormone is produced, nor is any hormone detected. These adenomas are usually benign in nature when they target the anterior pituitary. So that's the good news, is they usually are benign. Now, I purposely cover cancer before I cover endocrinology, because a lot of our, not all, but many of these abnormalities come from adenomas in the pituitary. okay, or lesions on the thyroid, for example. And so now they're upregulating or downregulating. Okay? So if we look at our clinical effects of an adenoma at the pituitary, you could have the optic chiasm that's pinched. That's the branching between the two optic nerves, right? The optic chiasm. So that optic chiasm is the nerve tract that sends half the signal from one eye to one side of the brain and then sends it over to the other side of the brain for that hemidecussation, where you get signals going to both sides. Or you could have cranial nerve impingement on any of the cranial nerves that surround that particular area of the brain. Hypersecretion, and the results, again, like we talked about, it's dependent upon the type of hormone that's being made. So if it's in the pituitary gland, and that adenoma is manufacturing too much thyrotropin-releasing hormone, right? I'm sorry, it's in the pituitary gland, and it's manufacturing too much thyroid-stimulating hormone, right? Then it's going to have clinical manifestations on the thyroid. You follow? If it's hyposecretion, the adenoma grows, like I talked about, to a point where it's too big, and now it's starting to put pressure on the surrounding tissue. And it can cause functional, healthy tissue in the periphery to slow down their production. So even though it's not going to metastasize and go somewhere else, it's still growing, and it's growing to a size where it's now impinging on secondary tissue sites nearby. And so that's where you probably need to come in and remove it. Either situation you may come in and remove it, hyper or hypo, but the hypos are usually the ones that have to be removed. The hypers are usually ones that maybe we try pharmaceutically to block their activity and watch to see if the tumor is going to get any bigger. If we look at a couple of examples that I was alluding to, we have gigantism and acromegaly. So if we have growth hormone that's being manufactured by the pituitary, that growth hormone comes from growth hormone releasing hormone that's manufactured by the hypothalamus. And growth hormone has effects all throughout the body. So it regulates metabolism in both muscle and in bone and in fat. And it's intimately tied to IGF-1, which is insulin-like growth factor 1. Why is that? Well, IGF, insulin-like growth factor, is considered to be the mediator of the effects of growth hormone. So growth hormone's activities are carried out by IGF, because IGF is produced by the liver, right? Growth hormone targets the liver to upregulate IGF. So when growth hormone gets to the liver makes IGF. IGF leaves the liver, and it stimulates cells in the body. Especially, now almost every cell in the body responds to IGF. But the ones that primarily respond, and respond very carefully, are muscle, cartilage, bone, liver, kidney, nerves, skin, and lung tissue. Like, isn't that the whole body? Yeah, that's what I just said. But those ones, muscle, bone, skin, liver, those are kind of the main ones that are necessary for growth to happen. If you're going to grow with muscle and if you're going to grow in stature, you need bones and muscle to go with it. Okay? So IGF kind of facilitates the activities of growth hormone. So in these patients with hypersecretion during childhood, before the plates close, they result in gigantism. They get very, very tall, very, very large. Okay? Big people. If that abnormality continues or happens after the growth plates close, then you get deformations that start taking place. Because you have metabolism upregulated on muscle and bone, but the bone isn't elongating anymore. Okay? So that's acromegaly. So acromegaly is more of the adult effect of high levels of growth hormone. Gigantism is the pediatric effect or the adolescent effect of too much growth hormone during the growth phase of the individual. So you can appreciate this individual up top who had gigantism, was a big individual, and then that growth hormone hypersecretion continued in adult life. So now you're starting to get some of the features in this gentleman. Very pronounced jawline, frontal bossing of the frontal lobe. Okay, you get very, very stark masculinization features. If you look down here at this woman, this is a young woman who had a growth hormone abnormality later in life. This individual was large as a child, grew up, was a big individual, tall individual, and the growth hormone continued to be released, so then the acromegaly started to manifest. This young lady progressed, and you can see a lot of masculinization types of features that take place in this woman as the growth hormone continues to have its activity on target tissue, even though the plates have closed. Okay? These patients typically not only do they have these growth abnormalities, but they do a lot of times suffer from type 2 diabetes and hyperinsulinemia. So why is that? Well, growth hormone, when it's released in excess, high levels, it has an inhibiting factor on peripheral glucose uptake because it reduces the cell sensitivity to insulin. And so if it reduces the sensitivity to insulin, okay, then they become hyperglycemic. There's too much sugar, glucose floating in the bloodstream, okay, and they start to release more insulin to have an effect on bringing that sugar in, and that's essentially the effect of type 2 diabetes that we'll talk about towards the end of the lecture. Hang on, the back and then up front. Okay, and then up front.
I was just wondering, did you say it was only for acromegaly, or is it for both gigantism and acromegaly, where they start to develop
Type 2, it's usually adult, so it's going to be more in the acromegaly phase. You don't typically see as frequently type 2 diabetes in children, generally speaking.
Right.
It does occur, but most of the clinical effects of type 2 diabetes is in adulthood. Years ago, we called it adult onset of diabetes versus pediatric diabetes, which is type 1. We're losing that nomenclature because now we're finding type 2 diabetes in children. And there's a close association of type 2 diabetes with obesity. It's not cause and effect, but they're very highly correlated. And we're also starting to see type 1 diabetics that are diagnosed in their adult life. Like now we're seeing patients that are diagnosed with type 1 diabetes like they're senior in high school or in college, like your guys' age. And people are like, oh, you have diabetes? Oh, it's the type 2. No, it's type 1. Oh, wow. So these nomenclatures of pediatric diabetes and adult onset diabetes are not really, the lines are being blurred. Okay. Yes?
So are both of those pictures, they're suffering from the same issue, or no?
Both of these pictures, they don't have the same issue. This one, the issue was growth hormone was hypersecreted as a child and continued throughout their life. These pictures on the bottom in this woman, growth hormone was normal as a child. And then as an adult, there was hypersecretion. Okay? Yes?
You know, causing the abnormal growth hormone release in adulthood?
The abnormal release in adulthood would likely be due to an adenoma. Okay, so it's probably an anterior pituitary adenoma that's causing growth hormone to be upregulated. Okay, most often, but it's not to say it couldn't be a hypothalamic problem with growth hormone releasing hormone. Remember that original question that I asked?
Yeah.
But usually we discover when you do a scan, you can see the lesion in the pituitary. I'll show you some pictures of what I'm talking about here in a second, like now. Okay? Perfect question. So if you look at imaging, we can take a picture of the head. This is a prolactinoma. This one is one of the most common hormonally active tumors that we get in the brain. So a prolactinoma is one that forms in what structure? Where are we? What makes prolactin? What's that? The adenohypophysis, otherwise known as the anterior pituitary. Okay, so we're in the anterior pituitary. And we see high serum levels, high blood draw levels of prolactin. And you can actually appreciate, this is a sagittal view. Here is the lesion right here that lights up pretty nicely with contrast. Over here, it's pseudo-colored for your convenience, color coordinated, so you can identify. And here is that optic nerve. And so there may be vision issues associated with this patient as well. So clinically, the physician, may notice that they have high serum blood levels of prolactin, higher than normal. They're having some clinical effects, like things in women that prolactin would actually be associated with. For example, galacturia. What is this? This is the spontaneous flow of milk, even though there's no childbirth or nursing is taking place. The woman may not even be pregnant, okay, and they're having milk let down. Or amenorrhea. You guys remember what this one was? Amenorrhea, covered 202 in the menstrual cycle, or the lack of a menstrual cycle is really what this is. So it's the absence of a menstrual period, which is very normal during pregnancy, because the woman's body is saying, well, I'm already supplying an organism with nutrition, I'm not going to become pregnant, so I'm not going to menstruate, I'm not going to release an egg that can be fertilized while I already have an embryo. Okay, so amenorrhea or galacturia, you get spontaneous milk flow in the first, and amenorrhea, you get a lack of a menstrual period. So the woman comes and says, I have vision issues, got some kind of weird things happening with my, cycle, or actually there is no cycle, and even more strange is I'm producing milk, and I don't know why. Okay, and so that's going to clue the doctor in to say, okay, we probably have an adenoma, and it's probably in the anterior pituitary. If it's in a male, okay, you're going to get different effects. Oligospermia. Oligospermia is a low sperm count within the semen. A reduced libido, which is a reduced sex drive. And potentially erectile dysfunction. Okay? So these are the things that how you would diagnose or figure out, all right, where is this problem and where do I need to look? Now, if it's hypopituitarism, what are some of the effects? Pituitary gland's not making enough. Well, it could be, for example, you have an infarction, meaning you have blood flow into that region of the brain restricted, and now you have tissue that's dying or dead, and now it's no longer producing hormone. That's what an infarction is. A TBI, that's a traumatic brain injury, because if you remember where in the sphenoid bone there was this little sort of divot where the pituitary sits down. So in trauma, right, head trauma, that could actually smack up against the sphenoid bone and cause lesions to take place. That could be traumatic brain injury, which could cause problems with the pituitary and lower the production. An infection in nervous tissue, okay, these infections can become more systemic. You saw an infection that targeted, this was a viral herpes virus, right, causing problems with Clive. Do you remember Clive? The guy that had the moment-to-moment consciousness from Dr. Miller's lecture. So that was a brain infection from the herpes virus that caused problems within what structures of the brain? It was the hippocampus, wasn't it? I don't know who said that. I was taking from over here. The hippocampus, okay? So he had problems converting short-term events to long-term memory. You could have surgical damage. You come in, for example, this is unfortunately rather common. Someone comes in with an adenoma, it's overexpressing, and the surgeon comes in, cuts out the adenoma, it takes a little too much. They're supposed to take margin or healthy tissue around it, and they take too much. You don't know. They're just trying to contain the tumor. And now, instead of making too much, you make too little. Okay, so that is a side effect of surgical correction on hyperpituitarism. Sheehan syndrome. This is only in women. The pituitary gland increases in size during pregnancy and becomes extremely vascularized. So women's brains get larger when they're pregnant, guys, just so you know. Okay. And then, because it's highly vascularized during delivery, if there's a lot of bleeding, you can have vasospasm or vascular spasms of the pituitary. And with that larger mass of tissue and an increase in blood flow with a decrease in blood volume, you can actually end up in with a postpartum hemorrhage or excessive bleeding after delivery. You can have an infarction that takes place of that pituitary. That's known as Sheehan syndrome. So you can actually have a pituitary issue postpartum as a result of blood loss. Sometimes it's reversible, sometimes it's a little bit more permanent. Okay? All right, last before we take a break, and I want to break after this slide because I want to dramatically contrast insipidus with mellitus. So hopefully the break will delineate in your mind the difference. Diabetes insipidus. Diabetes insipidus is too little antidiuretic hormone secretion because this is a problem with the posterior pituitary. So I talked about a couple in detail of anterior pituitary. Now we're moving on the posterior aspect of talking about the posterior pituitary. And this undersecretion or this hyposecretion of antidiuretic hormone, ADH, also known as vasopressin, means that the pituitary gland isn't making enough of this, and so you lose lots of fluid in your urine, a lot of water, and you're not reabsorbing and concentrating the urine. So to remember this, insipidus is a Latin word that means without taste. Okay, because it's lots of water, so it's diluted out without taste. Insipidus. And the word diabetes means siphon in Latin. So diabetes insipidus is siphon without taste, is the word. So it's referring to siphoning water, essentially, okay, out of your body because you're losing the fluid. And so now you're going to have two main effects. You're going to have polydipsia, which is excessive thirst because you've excreted lots of your urine, and you're going to have polyuria, which is excessive urine production. So there's two main causes of diabetes insipidus. Posterior pituitary problem. Diabetes mellitus, we'll talk about after the break at the end of the lecture, has nothing to do with the posterior pituitary. Okay? In fact, the word diabetes mellitus, diabetes means what? Siphon, what? Siphon, and mellitus is a word that means sweet like honey. Okay? So you're siphoning sugar with diabetes mellitus, and diabetes insipidus is you're siphoning water. So you have two completely different clinical issues here. So diabetes insipidus, siphoning water. If you've got a neurogenic effect, this is going to be the most common, and it's because the posterior pituitary gland, those axons, are not making enough ADH. Nephrogenic is saying it's at the level of the kidney, the nephron. So nephrogenic is usually associated with end-stage renal failure, and it's the inability of the kidney to respond normally to antidiuretic hormone or vasopressin. So you make it just fine, but the kidneys don't respond to it. So you can have a neurogenic issue, which is the most common. It's in the posterior pituitary, or in end-stage renal failure with these patients, you could actually have a nephrogenic problem at the level of the kidney. Okay? Question?
So you said that the hypothalamus makes ADH not like this,
No. The posterior pituitary makes ADH and oxytocin. Well, so it is produced in the, yes, you're right. So the axons start in the hypothalamus, or the cell bodies in the hypothalamus, and the axons project down into the posterior pituitary. So the real answer is the products are made in the hypothalamus, and they're pushed via axonal flow to the posterior pituitary, which is where they're actually released from. But a lot of times we just say the posterior pituitary releases these hormones. The manufacture arguably is in the hypothalamus and part of the posterior pituitary. So the posterior pituitary is like an extension of the hypothalamus. Okay?
So the symptoms are polydipsia, polyuria, and hyper what?
Sorry. What would it be? Oh, hypernatremia. Thank you for pointing that out. So hypernatremia is too much sodium in the blood, because if you're releasing all your water, right, you're leaving a lot of salt in your bloodstream. So you have hypernatremia. Okay? Very dilute urine with not a lot of salt in it. All right, let's take a break here, and we'll pick it up here after the timeout.